Hi everybody, I'm Howard Danenberg, and this is Mark Sanders, and we're here to teach you ankle joint manipulation. Ankle equinus, or the inability of the ankle to dorsiflex fully while the knee is extended, represents a significant problem in the management of biomechanics of human gait. And there is a very simple and easy to perform manipulation which can completely reverse this process spontaneously. And I'm going to show you that right now. About 40 years ago, Mark hurt his lower leg with a compound fracture of both tibia and fibula. And since then has had some limited range of motion. His ankle does fairly well, stays active, but the range of motion is now starting to catch up to him, and he is here to have that managed. Ankle manipulation is a safe and easy to perform procedure, but there is a contraindication, and that is inflammatory arthritis. People with rheumatoid arthritis or psoriatic arthritis or any one of those inflammatory type diseases, manipulation is specifically contraindicated. Trying to move a joint when someone is hot and inflamed is something you need to completely avoid. So the first part of the examination is to see what the actual range of motion of the ankle joint is. So to start, you take the knee and hold it fully extended. Take the subtalar joint, put it in neutral position only to reproduce the actual examination later on during the course. It doesn't have any other purpose than that for this. And hold it straight, and then have the patient actively dorsiflex their ankle. And you can see how limited the total range of motion really is. And if you look here, he's actually driving the ball of his foot up. But if we keep that straight and keep his foot in neutral, and now try to dorsiflex again, Mark, yeah, there's almost no range of motion there. So we need to treat that. Treatment involves several aspects. The most important is mobilizing the fibula. The fibula is the smaller of the two leg bones, which runs from just behind on the lateral side of the tibia at this point on the leg, runs all the way down and forms the lateral malleolus on the outside of the ankle. There are two aspects to manipulating this. The first is to mobilize the proximal end, and then to mobilize the distal end. One of the interesting aspects of loss of fibular range of motion is that it also causes an inhibition of the muscles on the lateral side of the leg, the perineal muscles. So if Mark bends his knee and holds his foot down, turns it out, you can actually test the perineal strength to see how that works. I'm just going to move this a little bit. Hold it down and out, and don't let me force it in. And he actually has very limited strength capacity. Try again, push out as hard as you can, and he can't resist that. He actually wears out the outside of his right shoe all the time, and that's become a real issue for him, and that's what we're going to try and solve. Now, for the ankle to dorsiflex normally, the talar dome, which is the part that fits into the ankle joint itself, is shaped this way, so it's wider at the toe end than it is at the heel end. So every time the ankle has to dorsiflex and the talus rock into that, the way that works is that the fibula glides or moves or translates upward and outward, cranially and laterally. And that expands the joint, allowing for the range of motion. Now keep in mind during walking, this is not in this position. The foot's down and the leg is moving over the foot. So for this to move, this has to work during full load. And that's what makes it so important and why range of motion becomes critical. And without the balance between posterior tibial and perineals, it's going to redirect him to be rotated outwards. So we're going to try and treat that right now. So the first part is to free the fibula head. It's very simple and basic. There's no audible or sound with this, and just be gentle. Always gentle. There's never a reason to be a bull in a china closet with manipulation. Gentle always is the appropriate way to do this. So the fibula head is right here. There is the most significant structure is the common perineal nerve, which sits in the fibular notch, which is right here. We're not going to be involved in dealing with that in any way, so just be cautious that it is there. You don't want to impinge it or press from the side. Take the base of your thumb, which is the thenar eminence, and place it right behind the head of the fibula, right there, and you can feel that abut. And then as long as range of motion in the knee joint is normal, you take the knee, you flex it in, and depending on your size versus the person you're treating, If you're little and they're big, you could reach all the way down and give yourself leverage. If you're big and they're small, you can reach up, and so you don't want to hurt them. And make sure, just with a test, to make sure there's no pain with this. And the adjustment is just like that. Very simple and easy. You don't feel anything, you don't hear anything. But that jars the proximal fibula and allows it to move. So there are certain cases where patients have either arthritic knees or painful knees or injured knees, and the ability to fully flex their knee in to mobilize the proximal fibula is going to be impossible. So in that case, what you can do is you still bend their knee, but now instead of using the thenar eminence, which would cause you to have to flex it considerably, you can actually just take your whole forearm and put it in like this and get the same effect without having to flex their knee so much that it's painful for them. So what we're going to do is now take the thumbs and cross them directly over the neck of the talus. You can palpate the head, and you want to be over the neck, and then you want to lean back and traction the talus so that there is adequate separation within the joint. Makes the manipulation much easier. And I try to just move it and wiggle it slightly, just to sort of distract the patient a bit, as to that they don't realize what's coming, although it's not painful. And then traction, dorsiflex to end range, and then in a rotational thrust, you come down and back, and then you just check range of motion again. So you hold the knee straight, put the foot in neutral position, and dorsiflex mark. There you go, and down again, and back again, and down and back. And you could, I don't know if you feel the quality of that change, but it's a lot more range of motion. And there's a second aspect to this, which is the cuboid. I'll show you real quick, because the entire ankle joint complex is very involved in allowing for dorsiflexion, and that includes the rear foot as well. And when the cuboid, the calcaneal cuboid, becomes restricted in its motion, it affects this too. And Mark clearly has that. So you test that by holding the back part of the foot straight, grabbing the fourth and fifth lateral columns of the foot, and pushing up. And there should be an upward range of motion. You'll see that when we're done. In order to make the manipulation as painless as possible, it's a lot easier if you can release the cuboid before you mobilize it rather than afterwards. So once the bottom is palpated and there's constant pressure on it in that fashion, you're going to take the foot and you're going to very slowly and gradually invert it while your thumb is continually on it. I'm only moving away so this is visible. And what you'll feel is a release under your thumb when you get to the right position. Keep in mind, this is a very discrete point. So the object is to go very slowly until you feel that first release. Once you feel that one, the next one is to take the toes and bring them down slowly while your thumb is still on the same location, and you'll feel a second release. Once that happens, then the adjustment is possible here without hurting the patient. You find the inferior cuboid, press on the bottom, very gradually invert the foot, hold the toes slightly down, hold them right there, Mark, don't let them move. And you actually feel a slight release in the cuboid. Keep your knee tight, don't let it bend. Take one hand, place it over the other, and just thrust in, right in the cuboid, and the range of motion increases rather dramatically. And now dorsiflex your ankle again. There you go. Good. Much better. And now bend your knee. Hold it all the way out. Don't let me force it in. Ready? Resist. And that's about as hard as I can push. And clearly there's an enormous change in strength to that. And that's going to rebalance his foot so that he's not so posterior tibially balanced this way and not rebalance the other. And that's ankle and cuboid manipulation.